Hi, I'm John Kitchens, and I'm a retina specialist with Retina Associates of Kentucky. We have offices in Lexington, Louisville, and throughout eastern Kentucky.
And I'm Dr. Paul Karpecki, and I'm an optometrist who is also associated with the Retina Associates of Kentucky, but also practices at Kentucky Eye Institute in Lexington, Gaddy Eye Centers in Louisville, and on faculty at the University of Pikeville School of Optometry.
So, Paul, we're here today to talk about care of the macular degeneration patient. And as you know, macular degeneration is a major problem that we face with our patients. You've seen it here in your time with Retina Associates of Kentucky. What are some of the ways that you think that we can better care for these patients?
Yeah, you're completely right. I mean, if you think about just the opportunity and the size, there's so much there, and yet perhaps this is one of the areas that's completely underserved if you had to look at all the disease states.
Yeah, and you know, there's 15 million patients at risk for vision loss out there from age-related macular degeneration. So 15 million people with intermediate to advanced AMD, and we're only seeing a fraction of those patients, and unfortunately, by the time they get to us, it's simply too late. How are some ways you think we can better identify some of these patients?
Yeah, that number is astounding because you think about, glaucoma, for example, and it's about 2.3 million people. We understand the importance of that. We're talking about, easily right here 6 times the size, and that's just intermediate stage AMD, not the entire spectrum of what we see. I'd say currently most of the identification is actually when the patient presents to an office, meaning they come in noticing their vision is a little blurry, or perhaps they have a yearly routine examination. But even then, if you talk about Neely studies and others we're going to look at, 25% of the patients were in this one study that were looked at were not shown to have a diagnosis at the time of presentation. So even with the routine visits, even what we're doing today, we're not picking up on this disease.
I think the identification of dry AMD, particularly in those at-risk patients, is absolutely critical. Essential to this is a dilated fundoscopic examination. I think that is the starting point. I think it's absolutely critical that the diagnosis is made at the primary eye care level with optometrists, general ophthalmologists, because all too often when they're referred to us too late, when they've already got exudative changes. And unfortunately, as we'll see and as we'll discuss, patients who have had exudative changes that have either gone unrecognized by the patient or unrecognized by the physician.
I think you're spot on. There's a study by Cervantes and a group that showed amazingly 78% of the people that presented to this level, secondary, tertiary kind of care level, had 20/50 or worse vision. Half of them were 2200, meaning technically legally blind. They're either being missed, or more often the patient is only finally presenting when something serious has changed in their eyes. So we have to do better to get them in earlier. So John, from your perspective, why is monitoring intermediate AMD so important?
Yeah, Paul, I think we really see the importance of monitoring these patients in the ARADS and ARADS2 studies, where patients with the highest risk categories have up to a 50% risk of developing wet age-related macular degeneration and vision loss in their fellow eye within 5 years. And so these are the people that almost are half the time going to convert over. And those are the patients that have RP hyperplasia, large soft drusen, patients who have choroidal neovascularization in one eye. Those are all risk factors that put patients into that ARADS 3 and ARADS 4 category, which we need a better way to monitor.
So how do you help docs or others, even primary care, who are working very closely, sending a lot of patients to you? What do you tell them in terms of identification of that intermediate stage AMD patient?
Yeah, well, so first of all, anybody who has wet in one eye automatically gets into that more advanced risk factor category. Anybody that you see RP hyperplasia, pigmentary changes in their macula, they're going to be at higher risk. And then the harder thing is kind of some of these large soft drusen or larger drusen, but it's critical to look at both OCT and clinical examination to identify those. And those are the patients that not only are going to benefit from ARADS vitamins statistically, but also would benefit from more intensive monitoring.
That makes a lot of sense, and those kind of go hand in hand. And the good thing is, I think our profession, especially both, really understand when to put patients on AREDS2 formulations. But I still have questions on it all the time about how to identify it at that stage. And so, like you said, the one large drusen or the multiple drusen, or the case where the one eye is already lost. And I tell my colleagues as well that, think of the one large drusen as at least the diameter of one of the vessels coming off the optic nerve, and that gives them a little bit of a reference for identifying that key patient. So then they can, as you said, not only put them on formulations that may work, but also monitoring at home. So John, we know that monitoring these intermediate stage AMD patients is very critical. Why is that?
Well, Paul, really what we want to do is we want to detect these patients who are at highest risk as soon as they convert, when they still have good visual acuity. Because we know from a variety of different phase 3 studies that the better visual acuity someone presents with, the sooner that they present after conversion from dry to wet macular degeneration, the better chance we're going to be able to have at keeping their vision. In other words, if somebody presents with 20/40 or better vision, we have an excellent chance at keeping them 20/40 or better. However, if someone presents rather late with 2200 or worse vision, the chances that they're going to be able to get back useful vision, 20/40 or better, is much, much lower. So the sooner we catch these patients as they present, as they convert, the better opportunity we're going to have to keep them seeing and keep them functional.
So we know this, that the sooner you catch them in terms of the VA, the more likely they are to maintain good vision. So since optometry knows that, ophthalmology knows that, how are we doing in that regards?
Not very good, honestly. When we look at the IRIS registry, which is one of the largest collaborative registries of patient data, started by the American Academy of Ophthalmology, over 2 million patients and over 250,000 patients with macular degeneration, we found that the average visual acuity at diagnosis of these patients is 20/80, which is frankly not very good.
That's incredible. I mean, you think about, the impact a 20/80 has. In terms of one, we know that they can only get so much better when you finally treat them at that stage. We know, independence is around 20/40 for daytime driving, nighttime driving at 20/70. They're already worse than that.
And if you look at some of the anti-VEGF trials, Paul, the best patients that we have are the 3-line gainers. And we see 3-line gainers 30 to 40% of the time. So if you're presenting at 20/80 vision and you gain 3 lines, you're just a little better than 20/60. And we have the opportunity, I think, with ways of earlier detection to detect these patients when they're 20/40 and keep them better than what they are currently.
That really validates another study that was pretty consistent to that. It wasn't as large as the IRIS registry, but also a very well done study that showed that the only 22% of patients presented better than 20/50. So again, very similar. And the other, about 30% of the entire group presented with 2200 vision on first presentation. So, I mean, everything you look at, and all of these studies are very consistent for showing you're right, we're not really doing that well yet.
And when you think about the bilateral nature of this disease, that's even second eyes. Second eyes presenting 20/80 or worse. We're losing an opportunity to keep patients functional in their golden years. So Paul, what are some of the obstacles to the early detection of wet AMD?
Well, you're right, there are obstacles. To quote the Neely study, just to put this in perspective, this was a clinical trial where patients who actually had AMD, clinically significant AMD, were not diagnosed as having it. And a third of those were intermediate stage. So that's just one study showing, I mean, we're missing 1/4 of them, and a good percentage of that group are at least intermediate stage already. So, I think it's a combination of things, really. I'd say 3 in particular, and then we can even go into more. But number one is, I don't think patients are realizing and presenting properly, meaning they may not notice subtle changes. It may be so gradual they're not picking up. And even those who may have a diagnosis already are just not monitoring it well. Number 2, I think doctors are also having trouble making the diagnosis in the sense that if I go back to when I was in school, we didn't have the technology. You basically were given a sentence that you're going to go blind slowly or quickly if it was wet or if it was dry. It kind of gave the inclination that you can't do anything for it. And I think there's still doctors who haven't realized how much more we can do and where we're at and what can be done in terms of monitoring, for example, in terms of formulations for slowing progression.
And I'll tell you one place that I think we've really lacked, and that is, despite all of these advances in technology, we're still using an Amsel grid. And as much as an Amsel grid is convenient for our patients, it's easy to give them it, we don't have time to instruct them on how to use it properly. Patients struggle with it. They struggle with knowing how to interpret it, how to do it repeatedly. And I think it's a limitation, actually, to this early diagnosis. It's better than nothing, but it's not as good as what we could have.
And I think sometimes it may not even be better than nothing, because there's this kind of perceived notion that that's all I need to be watching for. And I think, as you'll see in some of the stuff we'll talk about, you can miss an awful lot. And so, yeah, I agree. It's better than not knowing anything or being around there, but I also think it gives a false sense of security sometimes. And they're not able to pick up the changes that are so subtle that are necessary to keep vision where it's supposed to be or improve it. John, I mean, if we look at AMD as a whole, what really is the impact of severe vision loss when it comes to the patient's quality of life?
I think that's something that we really lose track of. We see so many patients every day with wet macular degeneration and limited vision, and we work at such a pace that sometimes it's hard to slow down and realize that it's not just their vision that's affected. It's their families that are affected. It's the patient themselves. We know that upwards of 40% of these patients suffer from depression when they lose vision from wet macular degeneration. We know that up to a third of them suffer from anxiety, worried that they're going to lose vision. They perseverate on it, and I don't blame them. I mean, when you have vision loss from AMD, you're constantly worried your other eye is going to be affected. If your other eye is affected, you're constantly worried you're going to be blind and be dependent on your spouse or children. It's incredibly impactful, and this is something that I think we just don't take time to slow down and look at.
And I've asked a couple of my patients as well who presented with pretty poor vision, and they're kind of getting through, and one of them, specifically said, the reason she feels fairly helpless is really because of the burden it puts on her children. So we forget that aspect too, that it's sometimes not even their concerns that, oh, I'm going blind, or I'm not my other eye, and that is a concern, but it's also, I think it gets to a higher level of depression and other things when they start feeling like I'm starting to impact people I love, or my spouse, or someone who has to do so much more for me now. And so I think these are all really important quality of life incidences that we need to keep in mind, which give us a reason for doing what we're talking about doing today.